Well, it is a great pleasure to introduce Carlo Martinoli. Of course, he doesn't need any presentation. Hi, Carlo.
Hi.
He's we can say, the king of the kings on ultrasound. He's a radiologist working in Genoa, in Italy. And he's an expert in every field of ultrasound, but he's actually a pioneer in peripheral nerve ultrasound. So this is your topic, Carlo. Very welcome.
Too generous introduction. Thank you very much, Esperanza. Thank you, Dana, for kindly inviting me to participate in this webinar, and good afternoon, everybody. So the allotted time is not very long, and I have to address two big topics: peripheral nerves and fascias. So starting with nerves, I'll try to describe the most important pathological condition affecting them, and so we'll discuss entrapment syndromes, inherited disorders, dysimmune neuropathies, traumatic injuries, and then tumors. But before speaking about pathology, it's good to describe the appearance of the normal nerve, and you know that nerves looks like electric cable. They consist of some fascicles visible here, like small tubes, plastic tubes, and they contain the axons, and the axons correspond to the copper wires of an electric cable. So you see here the fascicles containing the axons, and within the fascicles we can find not just axons but also Schwann cells and myelin sheath. This is a dissected nerve, and you see the corresponding ultrasound image showing in its cross-section the fascicles as around hypoechoic structure. And the hypoechogenic tissue separating them from each other is the interfascicular epineurium, so it's a fatty stromal tissue. So when we speak about nerve ecotexture, we have to consider that this structure, different from tendons, don't feel anisotropy. So if you tilt the probe obliquely over them, you don't have any change in their ecotexture. So, and this is a fascicles with the structure we described before. So the technique to scan nerves is something like a video game. It's very important to know the landmarks, the anatomical landmarks. Once the nerve is identified based on the landmarks, then you take off and you can follow the nerve from proximal to distal or from distal to proximal in a few seconds, as you can see here. And in a few seconds, you are able to identify any pathology affecting the nerve in itself or the surrounding structures. So it's a very efficient technique to image long segments of a nerve. On the other hand, remember that on MRI, this is not really possible due to the fact that MRI require the use of coils, and coils restrict the field of view. So the technique is very effective to identify pathology, even affecting small nerves. In this case, we have an example of the ventral and dorsal sensory branch of the radial nerve. We are speaking about a structure that is 0.1 in caliber, and at the end, following the nerve in its cross-section, at the end we find pathology, in this case a terminal neuroma. The nerve was severed by a penetrating trauma. So after that, remember that one of the most important points, most important pathology affecting nerves is the compression of nerve trunks, the entrapments that usually occur at the level of the osteofibrous tunnels. And in case a nerve is entrapped, we have the nerve flattened at the level of the compression point and swollen proximal to the compression. This is an example of a median nerve examined at the level of the carpal tunnel. You see the gliding of the flexor tendons, and you see the notch sign, the abrupt change in the nerve caliber here. So if we scan the nerve on transverse planes, we can realize that in long-standing chronic compression, the fascicles becomes bigger and the echogenicity of the epinephrine reduces to make a more homogeneous appearance to the compressed nerve. So this is an example of a compressed median nerve, and you see that we are not longer able to demonstrate the individual fascicles because the nerve appear homogeneously hypoechoic, except at the point of maximal compression, in which it may appear more echogenic as a result of the squeezing of the fascicles. And this hypoechoic swollen appearance depends on edema and vasocongestion in the early phases, but later on it may be caused by intraneural fibrosis. So based on the EFSUMB guidelines, we concluded that an area, a cross-sectional area of 10 millimeters square for the median nerve, the carpal tunnel, together with the wrist to forearm ratio of the median nerve, should be a good indicator to identify median nerve compression with strong strength of recommendation and good consensus. At the same time, for the diagnosis of the carpal tunnel syndrome, the cross-sectional area measurement should be considered complementary to the electrodiagnostic tests. And finally, if we discuss other sites of typical nerve compression, the second, the most common, is the compression of the ulnar nerve at the level of the epitrochlear groove. And again, in this case, the cross-sectional area of the median nerve to be used as a threshold between normal and pathologic is 10 millimeters square. This is the cutoff value for diagnosing ulnar nerve entrapment in the elbow area. If we refer to denervation of muscles, ultrasound is of course able to identify the changes in the muscle following injury or a problem affecting the function of a motor nerve. Remember that the ultrasound is a bit less sensitive than MRI in the early phases of denervation due to the fact that we don't have any volume change of the muscle in the early phase, just a mild increase in echogenicity that can be perceived better by MRI due to the higher sensitivity to identify edema and water using fluid sensitive sequences. In the late phase, the muscle volume reduces and the diagnosis may be easier, also for the fibrofatty atrophy of the muscle. Here we see three muscles and we have an increasing severity of changes affecting them in terms of ecotexture. The atrophic muscle becomes more and more echogenic, as you can see here. And this is an example of MRI in which you see the territory of the peroneal nerve very hyperintense on T2 whited sequences as a result of accumulation of extracellular edema. And this is typically occurs as a result of denervation. Moving to inherited neuropathies, remember that these conditions are very underestimated and because they are much more frequent than the clinics is able to, the percentage the clinic is able to recognize. A typical inherited neuropathy is a Charcot-Marie-Tooth disease occurring in 1 on 2,500 people. And this kind of condition is characterized by atrophy, by a genetic anomaly affecting the chromosome 17 or the chromosome X, depending on the forms. Is a very heterogeneous condition. And in the case in which this kind of neuropathy is associated with demyelination, we may see an abnormal shape of Schwann cells at histology, the so-called onion bulbs. And this characterizes bigger fascicles. Ultrasound is able in these cases to identify the demyelinating forms as the fascicles of the affected nerves, that are all the nerves in the body are affected, of course, in this condition, appears swollen. The ecotexture is normal, but the nerve is much bigger than expected. And this is a comparison between the demyelinating forms and the axonal forms. The axonal forms are associated with the normal nerve size. And this is another example of a Charcot-Marie with a big sciatic nerve in the thigh. Another class of disorders is represented by the dysimmune neuropathies, in which there is an autoimmune aggression against myelin sheath antigens, against Ranvier nodes, paranodal proteins, and we have a series of conditions taking part in this class of disorders, including the Guillain-Barré, the CIDP, the multifocal motor neuropathy, MMN, and other minor forms. In cases of demyelinating polyneuropathy, we may have a focal thickening of individual fascicles of the nerve as a result of an abnormal tissue due to the attack of these antibodies and the increased content of water of the fascicle. This may create multifocal changes at the level of different fascicles, changes in fascicular echogenicity, and that can be easily recognized with ultrasound. You see here some of the fascicles of the median nerve. This is the brachial artery. You see the very edematous changes affecting these fascicles in the case of CIDP. And on a magnetic resonance imaging, the same condition appear as a very hyperintense nerve due to the accumulation of water and to the demyelination process. So in the polyneuropathies considered as a whole, including the inherited and the dysimmune neuropathies, the conclusion of the group was that ultrasound may be used to detect nerve alteration in this condition. There is not much experience, and as you can see here, the level of the responses were not very good. But probably in the next future, with more experience, with the availability of a high-frequency transducer, of highly performance of the available technologies, probably ultrasound will gain position in the evaluation of these neuropathies. Regarding traumatic injuries, remember that ultrasound is able to detect the transaction of nerve trunks, and in these cases, the diagnosis is based on the demonstration of a discontinuity between the two nerve ends. Remember, in the case of a complete nerve transaction, you see the proximal stump here ending in a neuroma, and this is the distal stump. Ultrasound has to measure the gap between the two nerve ends, but it's also important to measure the distance between the base of the two neuromas, because the two neuromas have to be resected at surgery. So remember that ultrasound is very accurate. In some instances, in penetrating injuries, you may have involvement of some of the fascicles of the nerve, whereas other ones are spared. This is a case of a dog bite. You see the median nerve at rest, and you see some of the fascicles affected with a neuroma. You can define the amount of the fascicle. In this case, approximately 20% of the fascicles are affected. And based on fascicular mapping, you can also understand the territory of distribution of these fascicles. In this case, they were directed to the middle finger and not to the rest of the area covered by the median nerve. So in cases of nerve injury, ultrasound should be used to identify, localize, and follow up full and partial thickness traumas. This is one of the best application of ultrasound, especially in the acute phases when we have edematous changes everywhere, when we have hematomas. Ultrasound is very accurate to categorize the kind of injury and to provide a perfect diagnosis. Moving to tumors, remember that in some instances, tumors arise from one fascicles. Other histotypes tends to envelope more than one fascicles. And this is a very important information for the surgeon. In a case, this is a typical example of a Schwannoma, in which one fascicle of a nerve, this was the median, is affected, is in continuity with the mass, whereas the other fascicles pass on the side of the mass unaffected. In this case, the surgeon may proceed with resection of the mass, preserving the continuity of the other fascicles. So this is another example of a Schwannoma. You see a video clip here in which you see the nerve proximally, then the big mass arising from one of its fascicles, and finally the nerve in a distal location. So the finding of value is the demonstration of the continuity of the nerve with of the mass with the nerve of origin. If not, the mass is just a hypoechoic mass of the soft tissues, and so the diagnosis is specific. Then, in terms of histopathological differentiation, of course, there are specific features for peripheral nerve sheath tumors, but for a precise differential diagnosis, the biopsy or the resection of these masses is needed to obtain a correct diagnosis of the histotype. So moving to fascias, remember that we have to consider a superficial fascia and a deep fascia. The superficial fascia is embedded in the subcutaneous tissue, and it separates the superficial fatty lobules from deep fatty lobules there. The deep fascia is located between the subcutaneous and muscles, and it may have a specialization like the aponeurosis, in which the deep fascia may thicken, and also it may be associated with the fascias investing in the muscles, the so-called epimesial fascias. So the pathology affecting the fascia is very heterogeneous. And the most important, at least for ultrasound, is the one affecting the aponeurosis. That may be the plantar fascia, the iliotibial band, or the lacertus fibrosus in the case of the distal biceps tendon. Here is an image of the deep fascia in the forearm. You see the superficial fascia located here in between two layers of fat, and then the deep fascia, as it appears, as a very thin hypoechoic fibrillar layer embedded in a hyperechogenic background. Of course, ultrasound could be used to assess a muscular fascia morphometric characteristic like thickness and echogenicity, as well as fascial sliding and displacement. But this kind of application seems to be not really affordable. This is because the fascias are very thin, and they require specific technology to avoid to include other structure in the measurement. Considering the aponeuropathies, they may resemble insertional tendinopathies. This is an example of a proximal iliotibial band syndrome. In the magnetic resonance image, you see the problem affecting the origin of the iliotibial band closer to the iliac crest. This condition may be due to repeated microtrauma, and it's the same condition related to the plantar fascia, and the ultrasound pattern is very similar to the plantar fascia or to the other tendinopathies like the patellar tendinopathy. In this case, you see the swelling of the fascia at the level of its origin, some fissuration within the fascial substance, and then the fascia that normalizes in a more distal location. And this is an example of plantar fasciitis. Another specific condition affecting the fascias is the so-called fibromatosis. And this may affect the palmar fascia in the hand, in the so-called Dupuytren disease. And this disorder is a benign fibroproliferative disease in which there is the proliferation of fibrous nodules within the palmar fascia, and this may create some cord-like attachment with progressive flexion contraction. In this case, ultrasound is able to demonstrate the continuity with the nodules with the fascia and is much more resolute than magnetic resonance imaging, in which this kind of pathology is depicted, but is less consistent in the image. Moving to the foot, the lateral disease is a very similar condition. It affects the plantar fascia in a location that is more distal than the origin, the area of the plantar fasciitis, and typically it affects the superficial fibers of the fascia. In both cases, remember, one of the key features for the diagnosis is to demonstrate the continuity with the fascias. If not, the mass you see is totally aspecific, is a mass of soft tissues. And so you have to be very careful because it may also be a sarcoma. So depiction of the continuity of the mass with the fascias is very important for a correct diagnosis. Thank you very much.